Hello and good evening to everyone. Today we have a very, very special show looking at long COVID and innovative strategies for managing this really, really debilitating disease, which is affecting people all across the world. And today I have the pleasure of having an international audience of people who I'll be very quickly introducing. So I am Dr. Philip McMillan. I'm based in the United Kingdom. I'm a physician and a researcher, especially focused on autoimmunity in COVID-19. And so we are going to be looking at four of our speakers who will be sharing their ideas. And then we have three panelists who will be discussing some of the concepts with each of the speakers and then everyone together. We anticipate the whole duration will take us about 2 hours. And after we have finished, we will complete the conference, but then we will continue to talk live if you want to stay with us. So I have the pleasure of bringing everyone in here. Hello, good evening to everyone. Thank you very much for joining us, and great to have you all. What I'll do is I'm going to ask everyone to just do a very, very quick introduction of themselves, and we'll probably go in the order that we're speaking. So I'll start with Tim, then Annette, then Shankara, Bruce Patterson, and then I'll get our three panelists to introduce themselves. So probably starting off quickly, Tim, in 30 seconds to a minute.
Okay, good evening, everyone. Thank you for attending. Tim Robinson's my name. I'm a retired GP, retiring after 30 years in general practice. And I now currently work for NHS England, the long COVID lead for the southwest of the UK. I also work in two separate post-COVID services, assessment services, both in the southwest of England. And finally, I'm working for NHS Improvement on the post-COVID assessment task force down here in the southwest region. So that's my lot. Thank you.
Thank you very much. And we have, where did Annette go? I've just temporarily lost Annette for a moment. Oh, there we go. Annette, and yourself?
Hello. Yes. Hi, good evening, everyone. My name is Annette Offringa, and I'm a general practitioner. I have my own practice in the Netherlands. And for the last 5 or 6 years, I've been doing research on disease mechanisms. And starting after this summer, I will be doing research in a research institute on systems biology. So there will be basic research. I've published 5 articles on COVID until now. And the sixth one is on its way.
Excellent, excellent. And we'll quickly introduce Shankara.
Hi, everyone. Thank you for joining us. I'm Dr. Shankara Chetty. I'm a general practitioner in private practice in South Africa, running my own practice. I'm a frontline worker, and I've been seeing COVID from March last year. So thanks again for being here.
Wonderful. And we've got Bruce Patterson as well from the USA. Hi, Bruce. Oops, we temporarily lost Bruce, but we'll quickly move on, and I'll ask John to give a quick introduction of himself.
Okay, I'm John Abeles. I'm a physician and a pharmacologist. I had a career in medicine and then the pharmaceutical industry as a drug developer, and then on Wall Street as an analyst of what's going on in the pharmaceutical industry across the board and all the research going on. After which I became a developer of emerging medical companies and a venture capitalist entrepreneur, and I'm involved with several biopharma companies that I've helped to promulgate and begin, one of which is involved in COVID.
Excellent. And we've got Bruce Uhal. Your mic is muted. Hi, Bruce.
Hello. Hello, everyone. I'm Bruce Uhal. I'm a professor of physiology at Michigan State University. I teach in the College of Human Medicine at MSU. And I've been a researcher on mechanisms of lung injury for about 35 years now. And just by coincidence, about 16 years ago, as we were studying the angiotensin system in the lungs, we started to look at this enzyme called ACE2. and to study what the normal functions of ACE2 are in lung injury. And of course, now we know that ACE2 is more famous as the primary receptor for SARS-CoV-2. So all of a sudden, I've unwittingly become a expert on SARS-CoV-2 infection mechanisms. So happy to be here.
Excellent. And Neil?
Hi, I'm Dr. Neil Bodie. I've been involved in biotech for 20 years. The first decade, I was studying primarily autoimmune diseases. And then through what started as antibody-dependent enhancement research in dengue, I got involved in infectious diseases. So I have knowledge of both autoimmune diseases and infectious diseases.
Excellent, excellent, wonderful. Bruce, are you able, Bruce Patterson? I think, let me just see if I can get Bruce to quickly say something. Is that working better, Bruce?
Yes, that's better. I'm Dr. Bruce Patterson. I'm the CEO and founder of InCell DX, a multi-omics single-cell diagnostic company focused on cancer, infectious diseases, and immuno-oncology. I'm a viral pathologist, trained at Northwestern, and was head of virology at Stanford University, where we were studying, obviously, HIV and other pandemics at the time.
Wonderful. Excellent. Thank you very much to everyone. And right before we start, I would just quickly like to share one of the focuses that I'm going to be doing in the next few weeks. So I want you all to look out for it in terms of people who are interested in what I'm sharing with regards to autoimmunity. So in the next few weeks, I'm planning to have a specific webinar focused on autoimmunity and COVID-19 and the potential implications with regards to vaccination. The focus of that talk will be primarily looking at autoimmunity in COVID-19, which is the research that I've been focused on, looking at some thoughts with mucosal immunity and potential autoimmune responses that could occur with regards to the vaccine spike protein, risk of re-exposure to the virus, and unusual clinical presentations. And this is an area that I have had a lot of interest in, and one that I'm planning to grow the interest in as well. So for those who are interested, look out for this link. It will be put in at the end of the conference, and I'd love for people to join in with it to ask questions when I'm doing it. So back to our main presentation. And so what we're going to do, as we said, we're going to have 15 minutes for each speaker. They can use the 15 minutes as they like. If they have any questions, then I'll certainly try and ask it towards the end of their presentation. We'll try and be nice and tight with our presentations. And towards the end, all the speakers will come in and speak with the panel. We'll be starting off with Dr. Tim Robinson, and we will therefore focus straight on that. So, Tim, are you about ready for us to start with you?
Absolutely. Ready, rearing to go.
Excellent. So we'll start and share your screen. Here you go.
Thank you very much. Thank you again, everyone, for attending. So my presentation is entitled Long COVID, Setting the Scene, and setting the scene for this amazing conference with, I think, about 4,000 attendees. Amazing. So full marks to Philip. So setting the scene, basically 3 questions: where we started, where we are now, and where we are going. So basically where we started. Okay, this is a British perspective. This is from a British perspective. And so I have searched the British Medical Journal, 2 keywords, long and COVID. No surprises there. So I've just drawn out any papers from research papers, editorials, comments, news, practice, that either of those words have come up in, and that is what I'm basing this where we have started coming up to where we are now. So basically, trouble ahead. December 31st was the first entry of COVID in the British Medical Journal. Okay, coronavirus disease first reported from Wuhan, China. Okay, 20 days later, January the 2nd, cases surge as official admits human-to-human transmission. Shock horror. Okay, 200 confirmed cases, novel virus emerged in China, including 3 deaths. Yes, I said 3. And outside the city, it's spreading, we're thinking. Okay, 11 days later, January 31st, WHO, World Health Organization, declares international emergency as death toll exceeds, wait for it, 200. That's all. So this is not looking good. Here we go, February 28th. So about a month later, how do we prevent the current epidemic? Yes, we're calling it an epidemic now. Okay, becoming a pandemic. Right. Okay. Literally 11 days later, WHO declares pandemic we are in a pandemic. All right. Okay. Editorial a couple of weeks later. This crisis requires a balanced approach that tells people what they and the health system can do without causing panic. Oh my goodness. And that editorial was entitled Ready, Steady, Go. And so off we go. March the 16th. Outbreak could last until spring 2021 and see 7.9 million hospitalized in the UK. The crystal ball wasn't working well on that day. Okay, a few weeks later, 6 million doses. So I was going to say before that. Okay, so we've got a pandemic and we've got a bit of panic and it's really taking off. And so understandably, we're all looking for treatments. How can we deal with this disease? What treatments can we try? So hydroxychloroquine enter stage left. 6 million doses donated to the US despite lack of evidence. Interesting. So what's the initial response? Remembering this is a British-centric presentation. What's the initial response from the UK Health Service? Well, basically, the Oxford group brought out guidelines for GPs, how the GP is going to deal with this. It had been going now for about 6 weeks. Then March 16th, first lockdown in the UK. A week later, the Prime Minister announces, you must stay at home, March 23rd. Okay, stay at home. So naturally, the whole nation started panicking. My God, if I get ill, I can't go and see a doctor because I've got to stay at home. So some guidelines came out published in the BMJ, a remote assessment for primary care. So the advent, this new thing of seeing patients remotely and doing telephone consultations only and video links was born. It was quite a rarity up until that point. And so, I was working at that time and, I was working in scrubs and behind a mask and gloves and an apron and hot zones, cold zones in the surgery and going out to the car park to bring those patients in. This was the new primary care. This is the new reality. This is the new norm. Moving on into April. Again, like I said, it was all kicking off and the Oxford group had produced the guidelines. Then the NICE, for those of you who are not in UK based, standing for National Institute for Health and Care Excellence, brought their guidelines out on how to deal with acute COVID. Okay, with everything kicking off and more cases, and we're approaching our first spike, then understand we've got to look into this. So let's look into it. March 20th, our first research was from King's College, and that was Professor Tim Spector, the COVID symptom study, the Zoe app. So this was mobile phone, self-selecting patients who are tracking their symptoms in the UK. And of course, thanks to this wonderful app, one of the cardinal signs for acute COVID was identified, and that is loss of smell and loss of taste. Fantastic. Moving on into July, we realized that actually these patients who have acute COVID are not getting better very quickly. And the phrase long COVID came into common day parlance. It's a patient-generated term, as you all know. It started off with long-term COVID in UK, and then long-haul COVID in US, and it's been compressed to long COVID, which is what we all know it by now. At the same time, in July, there was the Italian study, knowing that obviously Italy, northern Italy, is where it all kicked off, first of all, in the West. So the lasting effects of long COVID were really being noticed now. The Zoe Act was not only great for the acute COVID, but also there are 4 million subscribers. So those symptoms were still being tracked for long COVID, a great resource for data collection. Further data collection from the NIH, National Institute for Health Research, came about, again, mentioning for the first time for this new phrase, long COVID. And then the REACT study, Imperial College, this was published in June of this year, studying 500,000 random random community sample of patients who had COVID. And this is headline quotes from Reuters. Over 2 million people in England might have long COVID. It identified the older people who are more likely to suffer from COVID. It also identified higher prevalence in persisting symptoms in women, in smokers, people who are overweight, people who live in deprived areas, and people who have been to hospital. So we're beginning to find out more about this big problem. So what's to do? Okay, so the Oxford group who had given us the guidelines for acute COVID then produced for us the guidelines for post-acute COVID-19. Note they've not called it long COVID. And then later on in December, NICE produced their guidelines, their rapid guideline for managing long-term effects of COVID. This was a very significant move because in it, they've actually defined long COVID for the first time. They looked at COVID, and basically COVID, they broke it down to 3 steps. First step, from onset to 4 weeks, so acute COVID. Then you've got ongoing symptomatic COVID from 4 weeks to 12 weeks, and then post-COVID syndrome from 12 weeks onwards. Very important to have that diagnosis in order to be able to measure something and look at those subgroups in the different presentations. So how's the NHS responded, and where are we now? Okay, so initially, July, remembering it all was kicking off in March, July, Your COVID Recovery website was created by the NHS, which is a self-management resource for patients about symptoms and how to manage them. October, the NHS brought out a 5-point plan for post-COVID syndrome. Okay, basically the 5 points are to bring about a definition. Well, that was done a couple months later, as I just explained from NICE. That was good. 10 million pounds was put towards assessment clinics for patients with long COVID. There was going to be further extension of this resource for patients, Your COVID Recovery, further research, and also the establishment of long COVID task force, which I'm a member of. Next response, April of this year, national guidance for the assessment clinics. Okay, so talking again about their definitions and the establishment of pathways. Also recognizing the need for addressing children and young people with long COVID. Prior to that, hadn't really sort of been given much attention. Data collection in primary care, and also some patient-reported outcomes and experience measures. Most recent and latest response from the NHS is the long COVID NHS plan, 21 to 22, 2021 to 2022, 10-point plan, 30 million now directed into general practice. We've got to get general practice involved. We need to work together as a team. We cannot do everything in our assessment clinics. Further investment, 70 million into assessment clinics themselves. Establishment of care coordination for patients to have that sort of direct link with someone. Establishment of 15 pediatric hubs throughout the UK. development of packages for pathways for patient management, your COVID recovery further development, an online rehab platform, data collection, equality, learning to bring sort of educational resources to primary care and also to secondary care on long COVID. And final point, to basically support the NHS staff with long COVID, remembering that many of those frontline workers were exposed to COVID, got COVID, many became sufferers of long COVID, having contracted it in their line of duty. Okay, long COVID in the coalface, at the coalface. This is what's happening in the assessment service, its structure and function. Remembering I'm sort of a GP lead in two different services, so I see it from two different organizations. It's a multidisciplinary approach. The assessment service is ideally a generalist-led, not a specialist-led. Why? Because, I mean, basically, long COVID is multi-system, multi-symptoms, multi-etiologies. So in a way, you need a generalist view. Many have been set up by specialists, but I think that it's important to emphasize that we need generalist input here. And so the team itself is, a clinical lead. So myself, physiotherapist, occupational therapist, mental health services, vocational services, remembering that vast numbers of long COVID sufferers are at the working age group. You need access to speech and language therapy for those patients who have swallowing problems, dietetics, but also direct access to cardiology, respiratory, neurology, for example, and others. So the service is essentially a holistic service, drawing from the sort of the biopsychosocial model to support patients to understand their symptoms. That's half the battle. Patients must understand what's going on, and also their prognosis, and to sort of manage expectations, to be realistic. Individualized advice and treatments. No, it's not a case of one size fits all. Each patient is different. Each patient has different presentation. It has to be individualized. It has to be a wide range of management strategies. Patients who have only breathlessness probably want just main emphasis on physiotherapy. Patients with main fatigue probably want the services of occupational therapy. The service should be both self-managed, but also self-supported, self-managed. So where are we going? I've touched on where we've been, where we are, and where are we going? Well, we're still searching. We are still searching for the etiology and mechanisms and treatments. And there's been so much research globally, which is fantastic. But basically, as it says here, we're decoding the unknowns in long COVID. So there we are, where we are and where we're going. So thank you very much for listening to me, and on we go. Time's running short. I don't think I'm
not to worry.
At 15.
Yeah. So don't worry. I think that what we're going to be doing is, because we've just about finished that 15 minutes, and so we're going to be coming to some specific questions that I'd like to ask you, Tim, when we're speaking with the panel afterwards. But we'll stop right here and we'll move straight along into speaking to Annette Offringa. Are you about ready, Annette, for us to start?
Yes, right. I am.
So I will share. Let me just make sure that I can share your screen, and there we go. Is that about right?
Yes. And now I need to be able to
control the button. So at the bottom on your screen, you should see these little arrows at the bottom where you can control the slides. Or if you click on your screen in the PowerPoint itself, it should move forward.
Yeah.
Mm-hmm.
Okay. Does it work like this?
Yes, so look, just right at the bottom, you can see your little arrows, yes, that you can move along.
Yeah. Okay, so I just made a few illustrations to support what I am trying to explain. What I want to explain is how I think the disease mechanism causes the complaints of long COVID. In Dutch, long is the word for lung, so that's a bit tricky for Dutch people who are listening. I prefer to call it post-COVID to my patients, because if I say long COVID, they may think I refer to the lungs. Anyway, I think it's important to know how the disease mechanism is to find treatments. What I do want to say first is that I can imagine that some people who are listening are suffering from long COVID and are quite desperate. This doesn't mean that I support people experimenting with treatments by themselves. I think people do need professional care. So that's first. Okay, we all know that the virus binds to ACE2 to enter the cell. And the ACE2 is an enzyme, angiotensin converting enzyme 2, which converts the enzyme angiotensin 2 into angiotensin 1,7. Angiotensin 2 is an enzyme which is activated when you have an infection, for example, or damage inside the cells. And that's part of the mechanism that restores damage or gets rid of the pathogens. Angiotensin 7 does the opposite. So that inhibits inflammation, inhibits the immune system, and supports homeostasis. So angiotensin 2, when that's activated by, for example, a viral infection, via the angiotensin 2 type 1 receptor, activates NADPH oxidase, and that produces superoxide. Superoxide is part of the mechanism that induces an inflammatory response. Angiotensin 1,7 does the opposite. It activates endothelial nitric oxide synthase, eNOS, which produces nitric oxide. And nitric oxide does the opposite, or it is anti-inflammatory. So angiotensin 2 induces the production of superoxide, and angiotensin 1 produces nitric oxide. If the virus binds to ACE2, then the virus takes ACE2 into the cell, or the other way around, perhaps. But anyway, ACE2 is no longer at the cell surface and can no longer convert angiotensin 2 into angiotensin 1,7. That means that angiotensin 2 is accumulated and produces more superoxide. And because the virus can enter the cell, you get more viral particles, which increases the infection and which also increases the production of angiotensin 2. So this is a vicious circle in which angiotensin 2 keeps accumulating while angiotensin 1,7 is not formed. So angiotensin 2, via the production of superoxide, induces inflammation, innate immunity. I put that in green here because that's an important response to infection or damage. It also induces blood vessels to constrict, so it causes hypertension. And it's also associated with fatigue and with negative effects on exercise training. And angiotensin 1,7 via nitric oxide acts anti-inflammatory, causes dilation of blood vessels, so it causes a lower blood pressure. It improves vascular structure and function, and it has a positive effect on exercise training. So if you want people to improve their general condition, then then you support them to exercise. That's what physical therapists will do with patients with long COVID, to have them to exercise to improve their general condition. So this is how enos produces nitric oxide. It needs the cofactor tetrahydrobiopterin, BH4, to be activated, and then it converts L-arginine into nitric oxide. So that means that you need BH4 and arginine to produce NO. What superoxide does is convert BH4 into BH2, and BH2 cannot activate enos. That means that you get enos uncoupling, and enos doesn't produce NO anymore, nitric oxide, but it produces superoxide instead. So you get more superoxide. What also happens via the AT1 receptor is that arginase is activated, and arginase is an enzyme which breaks down arginine. So that means that arginase also diminishes the production of nitric oxide. So what I think the goal should be for treating long COVID patients, I think they have increased activation of superoxide by angiotensin II because of disruption of ACE2 mechanism. So what I think we should do is inhibit superoxide production and facilitate nitric oxide production. That sounds very easy, but we need to find the right combination of medicines to achieve that goal. So inhibiting superoxide will reduce inflammation, constriction of blood vessels, and the production of nitric oxide should be improving the vascular structure and function and induce positive effects on exercise training. So if this would be the main mechanism of long COVID, then I think we should be searching for treatments that reduce superoxides and facilitate nitric oxide production. That was my story.
Excellent, excellent. So in terms of the nitric oxide, Annette, what do you think is a good way to improve the amount of nitric oxide from a practical point of view for people who may be suffering from long COVID? Is this a medication treatment versus just...
What I think, what we could do, let's have the right slide. Angiotensin II activates superoxide production via the AT1 receptor. The AT1 receptor can be inhibited or blocked by blood pressure medication, angiotensin receptor blockers, like candesartan, telmisartan. So I think that's the most important thing we should use to inhibit superoxide. And after that, when you've achieved that, you could facilitate nitric oxide production, for example, by suppleting BH4, tetrahydrobiopterin, that's available as a treatment.
So that's injectable B12?
I think injectable B12, what that does, it's a superoxide scavenger. Mm-hmm. So I think that injectable B12 increases BH4 by reducing superoxide. Mm-hmm. But BH4 is available as a treatment for children with phenylketonuria, PKU.
Okay.
So it's not a treatment that's prescribed often,
Mm-hmm.
but it's just supplementing your own BH4. Only you need to reduce superoxide first, because if you give people BH4 and they still have high levels of superoxide, then they will oxidize BH4 to BH2. And that's not what
is this something that people have access to? And does it need to be prescribed?
That has to be prescribed, yeah. And it's off-label. So I think that there should be solid research before it's prescribed to many people.
Mm-hmm. And in terms of the long COVID symptoms, do you think the severity of or the duration of the symptoms are related to depletion of ACE2?
I think it does, because ACE2 depletion by the virus disrupts the orchestration of angiotensin 2 and angiotensin 1-7. So I think that superoxide increases excessively during COVID, and NO production is inhibited because of lack of angiotensin 1-7. So I think we should try to level that back up and get that orchestrated again, because if you have people exercising, for example, with a physical therapist, then if they exercise when they cannot make nitric oxide, then they will make more superoxide because of the uncoupling of enos. If you the enos is activated by exercise. It's made in the vascular lining cells, endothelial cells, and it's activated when you exercise, but only in healthy people. So if people are not healthy or the blood vessels are not healthy, then enos is uncoupled and produces superoxide instead of NO. So if you have people who are still ill, too fatigued, if you have them to try to do physical exercise, then they will only produce more superoxide, and you get the opposite of what you want. And I think you will have to know that lots of people with fatigue, they are also already at the limit of what they can do in a day, when they've only put on the outfit for training.
Mm-hmm.
So
an interesting question just popped up about inhaled nitric oxide in this. I don't know if you've ever come across that. Just some thoughts. We can explore it later, but just whether or not you had any thoughts about it on this point.
Now I get to use my spare slide. This is my spare slide. Okay, superoxide and NO, they react together to form peroxynitride. And that's also pro-inflammatory. So if you still produce superoxide and you give the patient nitric oxide, then they will mainly produce peroxynitride, and that's not what you would want. So you will have to reduce superoxide first before you give nitric oxide. And if you suplete BH4, then you will give the body the opportunity to decide how much NO is made. So the regulation is more in the body instead of just giving NO.
Excellent. This is a very interesting concept, Annette, and I think certainly, I'm sure the panel will be wanting to get some more understanding with regards to what that would mean for patients. So certainly that's something that we will be coming back to with regards to the panel. Thank you very much for your 15-minute presentation, and we're going to move straight on, and we'll next be talking to Dr. Shankara Chetty. So Well, thank you very much, Annette, and just stay with us and we'll talk to you a little later.
Thank you.
Thank you. So, Dr. Chetty, do you mind just quickly introducing yourself and letting us know your thoughts with regards to long COVID?
Thank you, Philip. Thank you for allowing me to share my experience on this platform. I'm a general practitioner in South Africa, and I've been seeing COVID patients as a frontline worker from March last year when it first came to my country. So I've taken the opportunity to examine every patient and try and understand the progression of the illness itself. Viral illnesses tend to have a set pattern that they follow. And it was my intention from the start to try and figure out what was going on, the pattern. There were a few things that I found that were unique to COVID illness. And there were a few things that were the usual with viral illnesses. So I think that's vitally important in my understanding or my perspective of how I treat COVID. Very early on, the initial presentation was that of a viral illness, the usual symptoms of loss of smell and taste, body aches, chills, and the rest. My initial interest was on the dyspnea that was reported globally and seemed to herald the start of the more severe hospitalizations and that kind of thing. The aim was to understand why people transitioned into hospital. I found early on that patients seemed to worsen on the 8th day. I had the usual spread of severity in the first 7 days. Some people just had a sore throat and they recovered in a day or two. Others took a little longer, had a mix of symptoms, body aches and pains, joint pains, fever. But in all, a majority of patients showed signs of recovery by the 5th, 6th, 7th day. But invariably, there was a subset of patients who suddenly presented with dyspnea. And it seemed to occur on the 8th day, exactly a week after the onset of the first sign of illness. And I found this very unusual. This onset of dyspnea seemed to have no correlation with the severity of symptoms on the previous 7 days. Patients that had very mild symptoms could present back on the 8th day with very sudden dyspnea and very severe dyspnea. And there were those that had very severe illness in the first 7 days, typical viral illness, that did not progress on the 8th day with breathlessness. And there was this disconnect that I noticed. It seemed to be nonlinear, no correlation with the severity of symptoms. So I became suspicious that we're dealing with a separate pathology. So very early on in the pandemic, we realized that this is a steroid-responsive illness. But I was very cautious about where to introduce steroids in the progress of this illness. So I thought when I saw patients presenting on this 8th day that would be the point where steroids might be of benefit. And so I promptly started treating patients that way. It took 2 or 3 days for them to start showing recoveries. But it seemed a subset of patients, not everyone progressed. About, I'd say 30% of my patients started deteriorating on that 8th day. And there was a difference in the speed of deterioration. Some patients would desaturate very quickly. Others would have mild desaturation, but it would be relatively prolonged. So I thought that this was likely to be an immune response to the virus itself and was more dependent on the body's reaction to the virus rather than the virus itself triggering this kind of process. The disconnect drawing my attention to such. So after about the 3rd or 4th patient being treated with steroids, I decided to add an antihistamine, seeing that I was under the impression that we were dealing with a hypersensitivity and most likely an allergen triggering it, seeing that people reacted very broadly as far as severity goes. And I also noticed a genetic predisposition. Father and son seemed to respond in very much the same way. Mothers in the same family did not progress on the 8th day. And so I added antihistamines to my treatment protocol. I preferred the older first generation antihistamines, being a lot stronger. And I noticed an almost immediate reversal in hypoxia. Patients with saturations as low as 70% started to show a rebound within a few hours. And that drew my attention to this being probably some sort of immune-mediated hypersensitivity. Very early on, I started to use montelukast to mop up the leukotrienes that might be released. We were aware of the clotting disorders that were occurring, so I added aspirin to the protocol. And so the modality of treatment was steroids, antihistamines, montelukast, and aspirin. So I was, in effect, treating a mast cell activation kind of syndrome. In that modality of treatment, I had very rapid recoveries of patients. And in the first wave, I didn't have any patients progress to long COVID. I had none of the post-COVID complications that people were noticing. And I found this strange in that all the patients that recovered, got off their medication, never presented back with any other symptoms. As we approached the second wave, I started to see patients with long COVID that were treated with different modalities and had persistent symptoms. Now, in the first wave, my understanding was that we were dealing with an allergen, and it was likely to be a type 1 kind of reaction. So I started to look for certain markers that might show this up. I noticed around the world, people were doing C-reactive proteins, a marker for inflammation, interleukin-6s, and D-dimers to show a risk of coagulation. I attempted to do immunoglobulin E assays on these patients. However, immunoglobulin E is not a very rapid marker, and it's not something that can be used to identify type 1 hypersensitivity on the 8th day, especially. It shows up a little more slowly. The other alternative was to look for a sudden histamine release, which required a 24-hour urine assay, and of course needed me to defer treatment for 24 hours while I collected that sample. And that was not pragmatic. Patients could deteriorate very rapidly. The other was tryptase, which again is not a very quick marker. And so the proof of this became a little difficult. However, the treatment that I used in view of this perspective seemed to show very rapid benefit. Patients were showing improvement within a day of starting treatment. As we approached the second wave, and I started to see patients with long COVID itself, I took the opportunity to start looking at IgE levels in those patients. And I found patients with long COVID to have markedly increased levels of IgE. The normal being below 100 international units. I've had patients with long COVID with values in the 4 and 5,000s. The treatment modality remained basically the same. I, in the first wave, started to look at or classify the severity of the illness from the 8th day, rather than trying to classify severity from the first day, because there seemed to be this disconnect between the first phase and the second phase. So from the 8th day onwards, I would classify it as a mild illness that seemed to be transient and self-limiting, a moderate illness that was not life-threatening but prolonged, which I thought was long COVID, and a severe illness, almost to anaphylaxis, with patients that would desaturate very quickly. And those were the ones that would end up in ICU. So in the second, or approaching the second wave, when I started to see these long COVID patients with very high levels of IgE, I started to treat them again with antihistamines, montelukast. In the second wave, we noticed patients as well having a lot of gastrointestinal symptoms. And again, I decided to add H2 antihistamines. And that seemed to be the only drug that settled those gastrointestinal symptoms down. So the modality that I use to treat long COVID syndrome is basically, I consider it to be a mast cell activation syndrome. And I use treatment to suppress that. In doing so, I found reasonably rapid recoveries. most patients showed about 80% improvement within the first 5 days of starting treatment. And I've seen patients now that have had long COVID for a year from the first wave, and even they showed a reasonably quick response. The immunoglobulin E levels that I noticed showed a decrease, and I've used those to map full recovery. So I keep patients on this modality of treatment till the IgE levels get back to baseline. I took care to exclude any other history of atopy that might show these levels to be high for reasons other than coronavirus illness. So I think that this needs to be investigated a little further. The high IgA levels might play an important part in understanding how this disease progresses. The symptoms, the wide range of symptoms, from the brain fog to the intermittent breathlessness, all seem to respond well to antihistamines and montelukast. However, there were those patients that had very severe COVID, had hospitalizations. They did show some system injuries. There were patients with COPD. They did show improvement, but not complete recovery. And I think that is likely to be related to injury rather than just a mast cell, a prolonged mast cell activation. So from my perspective, I think that we're dealing with a severe immunologic condition that presents in a variety of ways depending on your predisposition. And a long COVID is basically a long-term hypersensitivity that's not that severe, but lasts a long while. And if we treat it accordingly, we get a reasonably good response timeously from a majority of patients. So I hope that the IgE levels get looked at in a little closer. I think it might bring a little bit of more understanding about the illness. And of course, I've started now looking at IgE levels in vaccinated patients, and I'm seeing the same, higher IgE levels in them. In vaccinated patients, they seem to rise a little earlier in the illness compared to the unvaccinated. That should draw some attention to an immune response there. Thank you.
Wow, tremendous, Shankara. So we have probably a few minutes left. And so this here, the IgE levels, which are very strongly associated, I guess, with, as we said, long-term immune hypersensitivity responses, like what we would see in asthma. In those conditions where you have an ongoing allergen, so say in asthma, pollen or whatever could have triggered it, why would these patients have symptoms that wouldn't resolve even after the viral infection? Or are you suggesting that maybe the viral infection is ongoing? Any thoughts on that?
I think, Philip, that the viral infection has subsided, but they might have either persistent exposure to viral debris, which is likely to be the trigger for the allergic response. This came to light more in the second wave of the illness itself. In the second wave, we had the notorious South African variant. And the only thing that changed in that mutation was the structure of the spike protein. And what I noticed was we were dealing with a more contagious virus. It had a propensity for gut receptors, gut ACE receptors, so more gastrointestinal symptoms, which ties into the affinity of a different spike protein. And I had a far more severe hypersensitivity or reaction on the 8th day, which required a far higher dose of steroids to try and control it. And that drew my attention to the spike protein being the possible culprit in this. So I don't think it's a persistence of viral infection, but rather a persistence of allergen, or possibly a triggering of an allergic response that is not suppressed sufficiently. Like you develop an eczema that, if untreated, would be persistent, and the body would take a long time to overcome that. Whereas if you treat it timeously, you could assist in mopping up all the mediators and turning off that tap that's causing the problem. So even a stat dose of allergen that's no more present can trigger a reaction that's prolonged. And even once the allergen's gone, if that reaction's not stopped, it will develop into a persistent reaction. We'll have a lot of mediators and things. So the perspective comes from my treatment of acute COVID. And I think that in acute COVID, my perspective is that on the 8th day, we're having some sort of a hypersensitivity trigger. And I noticed that antihistamines alone at that early stage are of the greatest benefit. But by day 11, we're starting to see hyperinflammation.
Oh, sorry.
We're starting to see some hyperinflammation, and that's where steroids become vitally necessary. By day 14, I started to notice the rise in D-dimer levels, and I think that's where the hypocoagulability comes in. But in all, I noticed if you catch it on the 8th day and suppress that hypersensitivity trigger, you can negate all the other phases of this. Patients that came later on had higher levels of D-dimer and signs of inflammation and required the full toot of treatment. However, those that were caught early, just with the treatment of antihistamines and montelukast, I saw the reversal of their CRPs and interleukin-6s and their D-dimers without the need for steroid or the anticoagulation. However, if you left that for a few days, the antihistamine alone wasn't going to reverse that. And I think the persistent hyperinflammation resulted in persistent hypersensitivity resulted in hyperinflammation, which was followed by hypocoagulability.
Excellent. We're going to come back to that, I'm sure, Shankara, in a short while. I'm just trying to see whether or not I can add Bruce. Bruce, is this the correct thing to use for you, or do you want me to use the other one?
In terms, I think I'm having problems with my computer, so I'll just do it from my phone.
Yes. Okay, fine. All right. Thank you, Shankara. We'll come back. Yes. Go ahead, Bruce.
So, CEO and founder of IncelDX, we now have over 6,500 long haulers in our program at IncelDX, which consists of using unique precision diagnostic tools and therapies that address the mechanism of long COVID that we just identified. To begin, in the early stages of acute COVID, what we found was that individuals who had acute COVID, they were better, they were alive, they left the hospital, but by no stretch of the imagination was their immune system normal. So much like the previous speaker said, they had symptoms that remained, their immune systems were still a mess. IL-6 is in the 50 to 100 range, and Rantes levels still over 30,000. And so we started to investigate what the symptoms and what the immune profile is of these patients who had symptoms for long periods of time versus acute COVID. And what we found using machine learning and AI was that they had a very distinct immune profile, an immune signature, if you will, that was very, very different than acute COVID. And of course, we published that in Frontiers in Immunology a few weeks ago. And, that also identified using a panel of biomarkers that we narrowed down from probably 150 biomarkers that we were using in the early stages of acute COVID. And we narrowed that down based on, what the function of these biomarkers was in the immune response. And again, not only did we find a signature for long haulers, and we created what's called a long hauler index using our algorithm, which is essentially IL-2 plus interferon gamma divided by the chemokine CCL4. And I'll talk about that in a moment. But we also found and concluded in the paper that we published that long COVID is truly a disease of vascular inflammation. Elevated VEGF, elevated soluble CD40 ligand, elevated TNF alpha, Rantes, and we see that time and time again. And then we asked the question, well, what's the cause of this ongoing vascular inflammation? And we had seen some immune cell subset abnormalities in long haulers in the previous paper. So we started to investigate a population of monocytes that was of particular interest to me when I was doing HIV research. And of course, monocytes can be classified as classical, intermediate, and non-classical monocytes. And what's very interesting is they all differ in their cell surface molecule expression and also in their function. For instance, classical monocytes express very high levels of ACE2, which would make them a target for SARS-CoV-2. And they express very low levels, if any, of CCR5, which made them relatively resistant to infection by HIV. Now, intermediate monocytes, which are CD14 positive, CD16 positive, have high levels of ACE2 and high levels of CCR5. And we had found previously that that was the monocyte subset that got infected readily by R5 isolates of HIV. Also of interest, that intermediate monocyte is involved in the pathogenesis of Zika and dengue fever in terms of crossing the blood-brain barrier and causing inflammation. Now, non-classical monocytes express very little, if any, ACE2. They express CCR5 and really function as antigen-presenting cells and patrol the vasculature. And they bind to endothelial cells through the fractalkine receptor pathway. And what we found in these non-classical monocytes, after looking at all the various immune cell subsets by high parameter flow cytometry, was that they contained the S1 protein months, 12, 15 months after initial infection. After we found that, we said, well, we're going to have to confirm this. This is such an important finding. So we actually sorted those cells, isolated those cells, and performed mass spectrometry on those cells to confirm that they contained S1 protein, which indeed they did. Then the next question that was somewhat obvious to everybody was, is there replication competent virus in these cells? So then we took the RNA from these sorted cells and we did whole genome sequencing of the SARS-CoV-2 virus and only found fragments of RNA. So here we have a cell that's expressing S1 protein months and months and months after infection, in these individuals who have these severe symptoms of long COVID. These cells are capable of crossing the blood-brain barrier. And most importantly, these cells are very capable of binding to the vascular epithelium and causing inflammation. And what we found is that this could easily account for the majority of the symptoms that we see in long COVID. And in fact, we concluded in our second paper that from the exercise physiology literature, that these cells are mobilized by exercise, which explains why to a person, long haulers have exercise intolerance. And now, having looked at thousands and thousands of long haulers and looked at their immune profiles and their cellular subsets, we're convinced that this is a major mechanism of long COVID. Further proof is in the fact that when we inhibit the migration of these non-classical monocytes using CCR5 antagonists, and also inhibit the binding of these non-classical monocytes to endothelial cells by disrupting the fractalkine pathway by using statins, that these patients get dramatically better and almost to 100% better in 4 to 6 weeks of therapy. And again, with a database that now numbers in the thousands of treated patients, and the fact that we're expanding globally into the EU and the UK and South America through various partnerships with laboratories. We're very excited about these results. We're very excited about the outcomes that we're seeing. And we've now expanded our program to look at the post-vaccination individuals who have long COVID symptoms and other diseases like post-Lyme, fibromyalgia, chronic fatigue, etc. You know, people have noticed that the symptoms are remarkably similar to long COVID. I wouldn't say that the pathogenesis is necessarily the same, but we've treated now, I would say, 50 or more post-vaccination long haulers, as we call them. And these patients have a immune profile that when we put it through our artificial intelligence program, where they were identified as long haulers, yet they'd never been infected by COVID by sequencing. And of further interest, they actually respond very quickly to the combination of CCR5 antagonists and statins. So they respond, I would say, actually quicker than long COVID patients because, you know, frankly, they haven't had the symptoms as long, and through our precision medicine and our biomarker panel, they don't seem to have the vascular inflammation or the extent of the vascular inflammation that that long COVID individuals have. And I'll tell you, for the first time, breaking news is that when we looked at the non-classical monocytes in post-vaccination long haulers, we also found the S1 protein. So we're actively confirming that right now with mass spec, and we're actively trying to put that story together, you know, in terms of the pathogenesis of post-vaccination long hauler symptoms, and get that out into the literature as well. Of interest, we've treated somewhere along the lines of 5 to 10 post-Lyme disease individuals, and 2 of them have responded dramatically and said that they feel better than they have felt in 3 years. So we're extremely excited that this pathogenic mechanism that we've identified, which is chronic antigenemia in the absence of replicating pathogen, is something that might be even more widespread than we bargained for. We know from the Lyme literature that the peptidoglycan coat proteins from the Borrelia bacteria can circulate for a while and indeed get engulfed by these subsets of monocytes, which of course allow them to migrate all over the body. So it's not a surprise that preventing their migration and preventing their binding to the blood vessels and causing vascular inflammation is relieving their symptoms that are very similar to long COVID. And I have to admit, you know, the responses are dramatic, and within, you know, 3 to 5 days, you see individuals that the brain fog has gone away, the tinnitus or ringing in the ears have gone away, and we're just very grateful for the collaboration with these long hauler groups. We've been pushing for them. We've been working night and day to find solutions for them to get benefits. We're now pleased to announce that our diagnostic tests are reimbursed, and our telemedicine visits are reimbursed. We don't know to what extent, but we're hearing really good news on the reimbursement front, because these individuals, not only are they debilitated, but they can't work, they're out of jobs. It's a tremendous economic burden, long COVID, especially if it affects as many as the 30% number that we've heard a lot of all individuals have been infected by COVID. We have a serious healthcare and economic issue that's about to arise. And it's something that we have to address not only on the medical level, but in the governmental level in getting support for these individuals. So I'll leave it there because, frankly, our papers are out. People can read about it. They can go to our site, www.covidlonghaulers.com, which, like I said, we're now enrolling post-Lyme, fibromyalgia, chronic fatigue, etc. So we may have to come up with a different name, but it's all about precision medicine, telehealth, and therapy directed at the cause of the problem and not just the symptoms. As we've been seeing scary issues with, some in the patients being treated with benzodiazepines, even opioids, just to feel better. When in fact, when you attack the cause, you take care of the symptoms. And I'll leave it there.
Excellent. I think we've run out of our 15-minute time, but it was well worth hearing the full 15-minute explanation. And I'm sure when we come to the panel, there'll be lots of questions around some of that work that you've done.
Sure.
So thank you very, very much, Bruce. And very shortly, we'll be coming back to our panel. Sorry about that. Let me switch us around. And so, yes, so that has been our 4 speakers, fascinating insights that they have all had, sharing with us some really, really interesting concepts about long COVID. And what we're going to be doing in our next section is that we're going to introduce our panel. And then our panel is going to speak for a short period of time with each of the speakers, asking them questions. And then we're going to have an open house chat, which may extend beyond the end point of the conference. But we'll be happy for you to stay with us until that point. So before I move on to that again, I'll take the opportunity and remind you that this is a conference series on LinkedIn that we are going through as many of the major topics that I can find with regards to COVID-19. We'd started with innovative upper airway strategies. This is our second one with regards to long COVID. And our third one is likely to be focused on outpatient treatment with regards to COVID-19. How can we prevent patients from coming into hospital? And this is of very, very significant relevance, probably more so to the rest of the world than it is to some of the first world countries who have managed to mitigate some of the disease through vaccination. But still, quite a lot of the rest of the world doesn't have resources. And if we can find ways that we can reduce the risk of patients needing to be admitted or needing intensive care facilities, that would be of great value to everyone. So that is our conference number 3 that will be coming up. Look out for details on that, and we'll certainly be sharing more information about the speakers and the panel with regards to that topic. I'll take the moment again to quickly also remind you again about the webinar that I'm suggesting that I'll be doing with regards to autoimmunity in COVID-19 and the potential implications for vaccination. And this is more to do with us trying to be clear about some of the things that can occur with regards to autoimmune responses. And I think this is becoming even more clear when we look at some of the work that Dr. Patterson had just said. We really need to be starting to think about how we can approach this disease from multiple angles and think of ways that we can help. So join us for that. We'll be happy for the support, and look out for the link towards the end of the webinar. We'll certainly be sharing it with everyone. So as we move forward, I am going to be introducing our panel, and I'll be adding first Mr. John Abeles. We have Neil Bodie, and we have Bruce Uhal. And so before I bring in any of the speakers, and the first one we'll quickly chat with is Tim, that was quite fascinating, wasn't it, guys?
Indeed.
Yes, very informative.
Mm. Yes, so what we'll do is we'll just quickly bring Tim in, and if there are any questions with regards to what's happening with regards to the NHS, any of the specific symptoms they may have noticed, it would be useful to hear from him. Hi, Tim, how are you?
I'm good, thank you very much, Philip. Well done.
So any questions, guys?
So, Tim, you outlined a lot of the pragmatic events and responses of the NHS in this regard. Has there arrived any kind of advisory on protocols to treat and deal with patients apart from the general supportive work and psychological and physiological, exercise, etc.? Is there a protocol of medication or nutraceutical or nutritional support that the NHS has arrived at?
With regard to the NHS, the answer is no, because the treatment currently is very much addressing symptoms, specific symptoms with conventional medication. For nausea, for example, using prochlorperazine. For the urticarial symptoms, using antihistamines, the non-sedating antihistamines. But with regard to more sort of current, so if you like, avant-garde treatments, that is not really part of the NHS protocol. It is chiefly on as I was presenting, sort of the package of treatments with regard to the symptomatology, using the various therapies specific to those symptoms, rather than pharmacological treatments suggested. Certainly at this point, using statins, I think we're all sort of holding back and waiting for studies to be presented and to see the efficacy. Likewise, antihistamines, a lot of physicians are actually suggesting it to patients, but with the caveat that, and the riders, that actually, we need to see the studies that actually demonstrate efficacy, as opposed to treating empirically, which is the way we're proceeding, empirical treatment. And so we're at the behest of clinical trials, waiting for them to show definite evidence. And I think that's global anyway.
Mm-hmm.
I was curious.
Sorry, go ahead.
Oh, I'm sorry, John. Go ahead and finish your line of questioning.
Just the one thing that links back to what Philip was saying earlier about the autoimmunity aspect. I mean, everything is sort of devolving down into the immune response, however you want to put it, and inflammation attendant with it. Many mechanisms may be at work, but the autoimmunity aspect, or the hypersensitivity aspect, as Dr. Chetty pointed out, is illustrated by the fact that you said, Tim, that you see the post-COVID syndrome much more in women than in men, which goes along with the epidemiology of autoimmune disease generally, that autoimmune disease is more common in women for whatever reason, and this may be another illustration of the autoimmunity aspects of the long COVID syndrome.
Absolutely, and it's very exciting that with all the research and long COVID now beginning to fall into various subgroups, and then with that in mind, then we can now begin to hone in on those subgroups and offer this sort of more individualized treatments according to which subgroup the patient's in. And I think it's a case of watch this space. And from my perspective, very much at the, as I put it in my slide, at the coal face. I see these different subgroups on a daily basis, and to be able to offer more specific treatments than just physiotherapy or occupational therapy, I think it's just we're desperate for, like you said, John. It's or Bruce, alluded to. This is a condition that's wrecking people's lives, and from a governmental point of view, it's going to wreck the economy. Well, it already is. So, so I think it's we are all waiting patiently for, specific treatments.
John, something, Bruce?
Hi, Tim. Great presentation. I was curious to ask what the UK's position was on what we call in our teaching in the medical school here the ACE inhibitor ARB controversy in COVID-19. With being interested in ACE2 and its role in blood pressure and so on, the notion of whether or not patients who are infected and were already on ACE inhibitors or ARBs for various conditions should remain on them or withdrawn, or what was I'm familiar with what was being recommended in the US, but what was the UK? What is the UK's position on that?
Okay, so here we are 15, 16 months on, and so it's been a roller coaster with a lot of therapeutics, hasn't it? So ACE inhibitors initially, it was sort of April, May time. There was very much the scare story going around that we should be withdrawing all our patients from their ACE inhibitors, and then there was a 180-degree about turn, and that was discounted. And I think that's more of that was an international realization. And so that initial fear that we were going to have to discontinue this massive cohort of patients on ACE inhibitors and ARBs was discounted. But then again, it's like I said, it's been a roller coaster, hasn't it, with so many treatments. Initially it was like, slam the patients with high-dose prednisolone, and then hold on, then that actually wasn't deemed the case, and that very cheap drug dexamethasone, oh hello, we should be using this now instead. So again, another roller coaster. Who knows when we start all giving our patients statins, because like what Bruce was saying, actually this could look good, this could be fantastic, but then again it may not. So we're just flying by the seat of our pants, really, aren't we?
Yeah, well, there is a lot of literature suggesting that especially AT1 ARBs may be beneficial for preventing at least the lung injury, if not organ damage in general. And in fact, if going back to Ebola, there were many lives saved by the administration of cheap generic ARBs and statins in Africa during Ebola, by preventing organ damage, it's believed.
Yeah.
So there's some support in the literature for the notion that an ARB would be beneficial.
Yeah, and then what's exciting is hearing what Annette was talking about, that by using the ARBs, hello, we can knock out the superoxide, which will enhance the NO. Fantastic. That's very exciting. If I read it right, Annette.
Yeah. So well, we've moved perfectly into quickly just bringing Annette into the spotlight. So thank you, Tim. I'm going to bring you back in the conversation a little bit later on. So any questions or thoughts from the panel with regards to Annette and what you're muted at the moment, Annette, by the way. Yes,
Yeah,
good.
I'm back.
Yeah.
Yeah.
Mm-hmm.
So Annette, so it's been stated that, and you alluded to it, that ARBs could in fact improve the disconnect that is caused by the virus connecting to the ACE2, and then disrupting its normal homeostatic division between oxygen radical production and then NO production as a homeostatic response to that. So that losartan and other of the ARBs would you would think would have a tendency to restore that balance, correct?
Yes, that's correct. Last year, on I believe it was the 14th of February 2020, because I was interested in research on these mechanisms, so I started to do research on COVID as well. And I immediately thought that if ACE2 converts angiotensin 2 into angiotensin 1,7, and ACE2 enters the cell with the virus, then you would want to inhibit the angiotensin type 1 receptor to reduce the excessive inflammation. So that's the first thing I started off with. And later I came to enos and uncoupling and production of superoxide versus nitric oxide. And it's very interesting because the other story about the mast cells. Mast cells also have enos, and they can also produce nitric oxide. They also have BH4. So I think it may be an escape mechanism to produce nitric oxide when endothelial cells no longer can produce it.
Aside from then encouraging investigation of losartan and other ARBs in looking at decreasing inflammation and enhancing NO production. NO is, as you know, has not only immunomodulatory effects, anti-inflammatory effects, but also has direct antiviral effects. And it's a very interesting intermediate in all of this. One of the things that could be suggested, I don't know how you respond to this, is what happens if somebody not only taking losartan and BH4, which you recommended could be looked at, but also to add arginine or citrulline to their to the mix to encourage NO production from that base.
I have seen good effect with arginine on someone with COVID toes and also someone with acute severe COVID. He was not in the hospital, but was expected to be going to the hospital anytime soon. But again, because the angiotensin type 1 receptor activates arginase, you will need to inhibit that first, because if you give someone arginine when his arginase is active, then it will break down.
So that's the BH4 property.
The BH4 is the activation of enos to produce NO.
Okay.
No.
Any thoughts, Neil? You've been relatively...
Yeah, as John pointed out, nitrous oxide has antiviral effects, and there's at least one group that has an intranasal nitrous oxide product. But it sounds like, from what you said, Annette, maybe that would be helpful as a prophylactic, but as a therapeutic, you have to decrease the superoxide, and it may be that giving nitrous oxide to COVID-positive patients is contraindicated. So, again, it's very interesting what you presented, and again, a caution as to using nitrous oxide as a, prophylactic when people don't know when they get actually infected with COVID and when it might become contraindicated.
You don't want to produce peroxynitrite, so you only should give NO if you have decreased the superoxide production.
Correct.
No.
This
You
brings
use radical scavengers or superoxide radical scavengers, glutathiones, N-acetylcysteine, large doses of ascorbic acid or tocopherols. All of those are radical scavengers. Would that suffice, do you think, to take care of the superoxide, element?
NAC, I think not. I think that's not strong enough. I have good experience with injected vitamin B12 because that's a very strong superoxide scavenger, almost as strong as superoxide
Carotene is also
itself.
astaxanthin is another.
Sorry?
Astaxanthin, it's a part of the carotene family.
Okay. And taurine. It's also it's a derivative that you produce from vitamin B12 metabolism also. It's like glutathione. It's a family of glutathione. So taurine you can take as a food supplement, but I do think we still need tetrahydrobiopterin as well. In my experience, that you need it as well.
What do you think about the possible combination of an AT1 ARB, say losartan, and sildenafil, which has been one of the recent clinical trials in idiopathic pulmonary fibrosis?
Yeah, I believe sildenafil also produces NO or increases NO production. So I always try to find something that is as close to the body's own mechanisms as possible. So that's why I prefer supplementation with tetrahydrobiopterin instead of sildenafil. But it may work, yeah, sure. Yeah.
Just a thought.
Excellent. And what we'll do now is that
the male patients would enjoy that too, right?
We'll leave that thought with John. So we've got Shankara here now. Thank you, Annette. We'll bring you back in shortly. So any thoughts, any questions from the panel with regards to, I guess, the IgE concept, the response in long COVID?
Sorry, go ahead.
I'm sorry. I was just going to say it was interesting what you're proposing as far as IgE, because most of the papers that I've seen have linked IgG immune complexes, and especially some that have abnormal glycosylation and binding to FC3A as implicated in severe or critical COVID cases and also long COVID. It's interesting as to whether it's IgG or IgE or a combination of both.
Yes, I think look, the discoordinate presentation of the illness shows a very specific time where worsening occurs. It's always exactly 8 days from the start of the illness. So looking at that, there's definitely some very definite trigger to this on that particular day. But the longer we allow it to persist from that 8th day, we're probably going to end up with a soup of mediators there, and it's going to show up a whole range of different pathophysiologies in the mix. But IgE is a very slow marker to show up. And I was looking for it more in long COVID, seeing that the likelihood of seeing elevated levels in those patients was there. And that's what panned out. Almost every patient that had long COVID had very, very high levels of IgE. So that drew my attention to an allergen being part of the pathology, or a pathogen in this immune mediation.
So have you looked at other, your intervention with montelukast and antihistamines? I mean, the antihistamines have multiplex actions, okay?
Yes.
They don't only block histamines, but they also have immune regulatory functions, because they're all anticholinergics, for example. And that could mediate immune, mobilization as well. So the use of antihistamines with a dramatic effect may, addressing a final common pathway of this hypersensitivity or immune complex driven response to S1 protein, as was pointed out by Bruce. The same thing with post-vaccination, syndrome, which bears some resemblance to long COVID. And it brings into question, I know Philip has been looking at this issue, that a lot of people who get the vaccines are reporting some lassitude and brain fog and exercise intolerance and all the other. It may not be as severe as long COVID, but it's certainly another aspect. So this hypersensitivity reaction is quite interesting, Shankara. One then would ask, are there less when you use these antihistamines? I mean, in a long COVID situation, are you going to get a very sort of especially the first generation antihistamines, you're going to get a lot of sedation and other side effects coming in from the antihistamines. So have you looked at the non-sedating antihistamines, the Claritins of the world, and see what they do?
Or if I could inject mast cell stabilizers.
Yes, like the chronoglycate, sodium cromolyn.
Yeah. Look, the older generation antihistamines do have a sedative side effect, but I think the rationale behind their use, it's dependent on the severity of the long haul symptoms. So those that have pretty severe symptoms, I generally start them on the older generation antihistamines, seeing that they are stronger. They tend to have a broader diversity of action as well. I do consider in some long haul patients to put them on a short course of steroid as well to try and suppress that reaction. However, I don't want to rebound once I withdraw these antihistamines. So usually promethazine or cyproheptadine, those first generation kind of antihistamines, I use for the first few days till I get symptomatic recovery. And then I tend to swap patients over to the non-sedative antihistamines. The one that I found works best is levocetirizine. Compared to the others, it seems to suppress the reaction and not allow the rebound. I do keep patients on the antihistamine and the montelukast for a period of at least a month after symptom resolution. The non-sedative antihistamine, the sedative antihistamines I do find difficulty in older patients. However, the sedation seems to, patients become tolerant to that after a day or two of being on those antihistamines. So I do use the non-sedative antihistamines, but I do reserve them as a follow-on treatment in those with severe COVID symptoms.
Have you tried any of the stabilizers like cromolyn?
Yes, I did consider ketotifen. However, with ketotifen, I didn't see the improvements the clinical improvements, but I do suspect that they will have some long-term benefit in those patients where we have rebound. As well, patients that have had other allergies prior to COVID infection. I find it vitally important to advise them to stay away from the things that they were initially intolerant to, because these atopic conditions that pre-existed seem to keep the reaction going. So the milk allergies and other food allergies and things need to be considered in those patients. And they need to be very vigilant of avoiding those triggers to prevent rebound of long COVID.
Thank you.
You know, one thing I just wanted to point out, because this is something I've run into in the past in autoimmunity, is that people and non-human primates are unique in that their mast cells express the activating FC2A, whereas all other animals have FC2B, the inhibitory. So we have to be very careful looking at in vivo data from animals that are not non-human primates and humans. And again, it may be a combination of IgG and IgE that's stimulating the mast cells, you know, so, you know, you may be treating both, but from a mechanistic standpoint, if we can inhibit those FC receptors, then that may help treat long COVID.
One of the natural, I'm always looking for orthomolecular types of approaches or nutraceutical approaches if one can, because pharmaceuticals often have, you know, multiplex activity which you can't account for, like the antihistamines. One of the mast cell inhibitors that we know is high dose ascorbic acid. And have you tried that in controlling not only your acute patients, but some of the longer haul patients as well?
Yes, John, I have used ascorbic acid, and it has shown benefit in patients. However, I find that the clinical improvement from the pharmaceuticals is much more noticeable. For those patients that have had long-term symptoms, I do put them on vitamin C for a reasonably prolonged period. I try and limit the length of time I keep them on the pharmaceutical interventions. However, I'm always cautious of rebound of symptoms. So I got to withdraw the pharmaceuticals very, very carefully.
Okay. Excellent. I'm just going to have to bring in our last speaker here now. So I think we'll bring everybody back afterwards. So thank you very much, Shankara. We'll be chatting with you a little bit later. So we've got Bruce with us here now. And so any questions for Bruce?
So Bruce, you know, I'm going to launch in here because it's a very interesting protocol that you're adopting. You're looking at CCR5 antagonists. I know of several. There is Maraviroc, which is on the market as a interferer of HIV attachment to cells, as an interrupter of HIV attachment. Is that there are others like there's
yeah, that's the one that's been
yeah, that's been approved by the FDA for HIV use. There is one in investigation. It's monoclonal antibody.
So, you know, our we've been using Morav. Yeah, correct.
Okay, and then you what statin are you using and at what doses?
Well, there's a humanized monoclonal called.
Hello.
So
is he?
Yeah, there's a number of different CCR5 inhibitors. There's the Shankara, which includes CCR2. Can you hear me?
Yeah,
we're hearing you.
Can you hear me?
Yes, we're hearing you. Can you hear us?
So yeah, there's a number of CCR5 antagonists. We use Maraviroc because, like you said, it.
Oh, we lost.
I think we temporarily lost Bruce. What we'll do is we'll just bring everyone in temporarily, and we're coming close to the end of the main conference, and I'm sure we'll be talking about these things after. It's Bruce. Can you hear us again?
Hello,
Bruce. Are you hearing us? Hello, Bruce.
Yeah, I can hear you now. Can you hear me?
Oh, okay. Yeah, I think the question was just about, yes, we are hearing you. Did you hear the question beforehand, especially the question about statins? Which one and what dose do you use?
Bruce, maybe you use the phone like you used before.
Yes. Okay. Let's just add in our other guests temporarily again. As we're coming towards the end, we'll shift back to Bruce in a little bit. And what I want us to think about is in terms of the issues that we're seeing, especially the long-term impact of long COVID. How does that play out for economies across the world? Are you hearing us again, Bruce?
So can you hear me now?
We can hear you, but you keep on breaking up. I tell you what you may do, Bruce, is switch off the video and see if the audio alone works. That may just take up a little less bandwidth. Can you hear anything, Bruce? Okay, not to worry. So as I was saying before, is that what we will do is that I just temporarily want us to think about where things are likely to go over the next year with regards to the impact of long COVID, both on economies. What is it that we need to happen? And this time, probably, I'll start with the thoughts from the panelists rather than the speakers. I'd say let's push John. John never has a word missing, so let's put you on the spot with this, John. Where are things likely to go?
Well, what is happening actually with this is that a lot of attention has been drawn down to long COVID, and it really illustrates the fact that a lot of our autoimmune diseases, which are very similar in manifestation, like fibromyalgia, like myalgic myeloencephalitis, chronic fatigue syndrome, and several of the other autoimmune diseases share a lot of similarities to long COVID. And it may be that the panoply of our autoimmune diseases out there are very similarly set off by viral infections, not only of SARS-CoV-2, but there's a post-flu syndrome. There are all kinds of other autoimmune diseases that may arise from post-viral syndromes. And all of them focus down on inflammation in various of its manifestations. And the interventions, however else they may be classified, all have effects on inflammation. Where are we going with this is that there are a lot of efforts now, including, I think Bruce has had a lot of experience in his protocol. Shankara's protocol bears investigation. Other protocols which are anti-inflammatory in their actions are underway. I myself am involved with a study with a intervention with a peptide that is non-immunosuppressive. And I think it's very important that when we engage with anti-inflammatory interventions for these diseases, that we don't suppress the immune system in so doing, which is very often the case with anti-inflammatories that are pharmaceutical, that the immune system itself is suppressed in order to get the anti-inflammatory response. And then other things may happen. You know, there are suspicions that perhaps people with long COVID have an evocation of latent viruses like EBV, Epstein-Barr virus, and other latent viruses that may be evoked when you suppress the immune system. So in intervening with these syndromes, I think the best approach is to try and find interventions that are non-immunosuppressive. And that's why I'm interested in the supplementation environment with evidence, not merely, anecdotes, but with strong scientific evidence that interventions with orthomolecular natural molecules that are nutraceutical in their nature can be an interesting avenue to pursue for the long-term safety of the patients.
Thank you. And Neil, any thoughts with regards to where we have to go with long COVID?
Yes, but before I start on my thoughts, John, a quick question to you. What is your opinion on quercetin? I've seen some anecdotal stories on LinkedIn, but I haven't seen any hard evidence. But as far as something that is an anti-inflammatory to mast cells, what's your opinion on that, John?
Sorry, you were cutting out for me. I don't know if other people had the same experience.
Quercetin. What is your opinion on the use of that for long COVID?
Well, I think, all of these things that have anti-inflammatory actions, and in the case of quercetin, not only being an anti-inflammatory naturally, but it's also a zinc ionophore. So, and zinc itself is an anti-inflammatory, and if you get an ionophoric activity of quercetin, that is similar to the ionophoric activity of hydroxychloroquine and ivermectin, both of which too are anti-inflammatories and ought to be investigated for long-term COVID. That quercetin is a mast cell stabilizer as well, and as such is a very interesting intervention, I would think.
Yeah. Okay.
We'll have to follow up on that, John.
Yeah, we'll be able to come back to those.
I think Neil and I are of similar philosophy, and he is looking at some interesting anti-inflammatory interventions using FC portions of antibodies, which have the natural homeostatic activity, are down-regulating. I'm looking at a peptide derived from alpha antitrypsin, which is a homeostatic molecule, an LRP1 agonist. And so all of these are means by which to intervene without really dousing and suppressing the immune system, which is an important thing. Steroids are very important to begin with because they are emergent, and as Chetty has said, very useful in the acute phase of the hypersensitivity catastrophe, the cytokine storm. But they should be used extremely judiciously in the long term, in my view. And these other molecules, that quercetin and other natural nutraceuticals, are worthy of attention.
Yeah. So I tell you, I just want everybody, we can continue to talk after, so don't worry. I just want you to get some final thoughts, and then we will continue the discussion after we've done the formal close. So just some quick final thoughts, and then we'll talk after, Neil.
Just again, Soluble FC2B. It was a product by company Supermol. It was acquired by another drug company, and they're not in the autoimmune arena. But if there's anyone watching that's involved in industry or has an interest, I can put you in touch with the person that was a lead scientist on that, and that's in my opinion one of the best drug candidates for long COVID.
Excellent. And Bruce, Uhal, any thoughts?
Yes, I'd like to echo what Tim was saying a few minutes ago about how we've been in some respects shooting in the dark and flipping back and forth in our views. But I think it's important to keep in mind that in some respects, when we come up with the therapeutic combinations, we're sort of working on a two-tier system. As you know, GlaxoSmithKline was pushing the recombinant human ACE2 back when they owned it before the pandemic hit for acute lung injury. It was in phase 3 for ARDS around the world. But a drug like that is so expensive that you're never going to get that in sub-Saharan Africa. So we need to also consider the kind of protocols that the retired pediatrician David Fedson is writing about a lot. Cheap generic drugs. And I like Dr. Chetty's approach. I mean, if we can use high-dose aspirin or antihistamines, cheap generic drugs that can be reached and provided to poor countries that can't afford recombinant human ACE2 or the Ang-1-7 peptide or congeners of that peptide that a number of companies are pushing. We need to keep that in mind for affordable protocols, even generics that can be that can reach the poor countries where there's a lot of suffering people.
Thank you very much, Bruce. And Tim, any final thoughts?
Yeah, my head is spinning. My head is really spinning. God, we've got drugs. We know how many different things have we talked about here. We've talked about statins. We've talked about ivermectin. We've talked about ARBs. And then we went to the nutrichemicals, which I'm full on with you, John. You know, go natural, go natural. But hold on, we've talked about zinc. We've talked about the ascorbic. We've talked about NAD, we've talked about quercetin, etc. I mean, this is why my head is spinning, and here I am at the coal face, and I have my patients coming to me saying, "What do I do, doc?" And I have patients who are coming in with a bucket of everything, and they're on their antihistamines, and they're on all the umpteen mega dosing vitamins, etc. And I think to myself, Christ, where are we going, etc. And it's confusion, and it is supplement soup. And hold on, Bruce, Uhal, you know, shooting in the dark. That's what we're at. But hold on, okay, what do we do? Do we do nothing? And in a way, John, your question to me is, what's happening? What are the protocols in the UK? And in a way, we're sort of like conservative with a little c. We say, hold on, let's just wait for trials and things to happen. And that's responsible medicine, that's evidence-based medicine, etc. But we're going to make a start somewhere. But God, where do we? My head is spinning.
I think we understand. Well, what about Annette? What are your thoughts as to where we go from here?
Yeah, the worst case scenario that I formed last year, February, was that COVID would induce chronic ACE2 deficiency, causing ongoing inflammation in a superoxide-rich environment, and not being able to switch back to the non-inflammatory NO-rich environment. So that was my worst case scenario, and I fear that I'm right now with long COVID. So I think we should aim at reducing the inflammatory state and switch back to the NO-rich anti-inflammatory state. And we should try to do that with compounds that are known to the body.
Right. And Shankara, any thoughts?
Philip, I'd like to reiterate, Bruce, your comments. I think we got to look at the population we're dealing with. In my situation here in South Africa, a lot of the new treatments are exorbitantly expensive, and that's very restrictive in the population that I treat. So I have to use what I have in my toolbox. And so I think when we understand the mechanism, the tools that we use become a little more clear. So we don't have any cross between different groups of drugs. The nutraceuticals in the environment that I'm in are expensive. The benefits are there. They might take a little longer, but I deal with the population where they want to see some resolution to symptoms and for the cheapest possible price. And that's drawn my attention towards cheap antihistamines, the mast cell stabilizers, leukotriene inhibitors, aspirins, clopidogrel. So I keep the medication as cost-effective as possible. So I think dependent on the countries we're dealing with and the population we're dealing with, we're going to have to tailor our interventions to that audience.
Excellent. I'm going to try and see if I can get Bruce Patterson in. Bruce, are you there? Can we hear you? I told him to switch off his video so that we can just hear the audio. Can you hear us at all, Bruce? It seems as though that that isn't making a difference. So just to explain to our audience, we're going to formally close the conference now. So I'm going to do an outro video. But what we're going to now do is that we're going to just continue talking, and we're going to look at some of the questions and points that people have asked and see if generally as a group we have any thoughts and ideas about that. And so for those who want to stay with us a little bit longer, that would be wonderful. But otherwise, look out for our very next conference in terms of what we'll be doing in terms of outpatient therapy to try and reduce the risk of patients getting into hospitals, the ideas and the treatments that are potentially available across the world with that. So thank you very much. Stay with us if you want to put forward any questions or points through the chat, and we will continue to discuss. So thank you very much for everyone who is still here. So let's bring everyone back in. I don't know if we can still get Bruce Patterson. Bruce Patterson, can you hear us? Still nothing. It's quite black. I told him to switch off his video to see whether or not we get better quality stuff. So let's target some of the points that I've seen coming up in terms of what people have been saying. So there have been lots of comments that I couldn't necessarily put on. Someone here is talking about affordable generic therapies of patent drugs can be enhanced to improve penetration. And I think Simon Cohen is specifically speaking about enhanced liquid aspirin to be able to treat long COVID. Any thoughts about that?
There are a lot of generics that are have been mentioned. In fact, I mean, let's go back to the old canards of hydroxychloroquine and ivermectin. Both of these drugs are immune regulators. I mean, hydroxychloroquine has been used in autoimmune disease for a long time, and with a long history of relative safety and efficacy in lupus and rheumatoid, etc. It also has antihistaminic effects, and by being a zinc ionophore, it's also got fairly interesting antiviral effects. So I think that post-COVID or long COVID could in fact examine this drug and ivermectin, which has very similar properties. It's also zinc ionophore. It also is an immunoregulator. It is an anti-inflammatory like hydroxychloroquine, and has direct antiviral effects of its own. Also can be explored. So these are cheap drugs, and other cheap drugs like off-patent statins are interesting. There are a whole slew of other relatively inexpensive interventions on inflammation. I'm particularly interested in, as are other rheumatologists, in the use of low-dose naltrexone as an intervention for regulating inflammation. It's a very interesting modality. Very low doses of naltrexone are TLR4 blockers, and also they are endorphin enhancers, and endorphins are salutatory on immune response. So that's a modality that can be looked at, and it's pennies a day. Scavengers such as one of the strongest, I think, is astaxanthin, which is a carotene molecule that's relatively inexpensive and has very powerful antioxidant and anti-inflammatory activities. That's another that I'm particularly interested in. So all of this boils down to what Shankara was saying, is that there is a huge menu of cheap generic off-patent drugs which are relevant to the big world, as Bruce was pointing out, Bruce Uhal. And also nutraceuticals that ought to be cheap, many of them, and can be deployed. When we get down to double-blind clinical studies sponsored by the pharmaceutical industry, then that's when you start to get the official treatments will come on board, and they're likely to be expensive. And one hopes that when those do come on board with double-blind studies sponsored by the pharma industry, that would take drugs like Meroverac, which is a Pfizer drug. It's used for HIV. It's a patented drug. That if they show double-blind studies that gets the orthodoxy really involved, that they would make those drugs available for the broad masses around the world at a price that makes some sort of sense. So that's why I think that, in the meantime, we can use these nutraceuticals, off-patent drugs, get the best studies possible to satisfy Tim, and then wait for the really expensive stuff coming along, which will inevitably come down the pike from the pharmaceutical industry.
We didn't get a chance to properly quiz Bruce Patterson and get some of his thoughts, but were there any thoughts about what he had been saying with regards to specifically identifying spike protein in the context of monocytes, and specific, it was, I think, intermediate monocytes? Anybody, any expertise or knowledge along that line?
Yeah, we've talked in the past about immune complexes as a result of long-term spike protein and then antibodies against that. And that was one thing that, unfortunately, the connection problems I wanted to ask Bruce Patterson. His atypical monocytes, they're CD16 positive. Is that just a blood marker like rheumatoid factor, or is that more a part of the pathology? If we can inhibit FcR3, CD16, that may help quite a bit in the treatment of long COVID. And then FC2A is primarily on platelets. That's the largest pool, and I think that contributes to the thrombosis seen in COVID and long COVID. So that's why I'm arguing that soluble FC2B may be the best treatment, because it would treat both of those aspects without, as John said, suppressing the whole immune system.
But would you have to inject those things, though, Neil? They're large.
It is. It's 60 kilodalton. It's not as big as an antibody, but you'd have to inject them or have something like Rennie Technologies robotic pill, but that's not going to be able to be used across the world because of the cost. So that's the downside of that treatment, is the cost. Yes.
I'm sorry we didn't get him to say which statin he was using and what dose. Has anybody else used statins in the context of long COVID? Is there any information
there's reference in the literature of statins being used both for acute and long COVID. Statins are known to be antithrombotic. They're antiplatelet they have antiplatelet activity, which is important in the context of the vascular inflammation and the attendant thromboses, and that can happen from that. But the statins have a generalized downregulatory effect on inflammation in general. They have anti-inflammatory effect. My supposition is that their use in cardiovascular medicine is more dependent on their anti-platelet effect and the anti-inflammatory effect than it is on the cholesterol effect, which I think is a paraphenomenon. So the use of statins is by itself is an interesting intervention, and a lot of them are off patent, as we know. Atorvastatin is one of the most common and I suspect it's as useful as any other statin. But the question I asked him was what kind of dose, because when you raise the dose necessarily to a level that he may want to go, you start bumping up against the side effects like myalgia, which is unpleasant and dose limiting. So I was curious whether we're in the range of statins that are at the low range or at the high range for his particular use of them. But as I say, they can be used in general as anti-inflammatories and anticoagulants as well.
I think that what Tim had said about the soup of treatments that are available, I think usually stems from the fact that we haven't identified primary pathophysiology. And that's usually what I think is always the problem. When you can zone in on exactly what is happening, you suddenly then have a range of treatment options that are, as Shankara said, dependent on your location. Whether or not it's at the timing, you may find that one person has not so high IgE, but high IL-6 and so on. And so your treatment will change depending on the characteristics of the patients. And so we really still need to get that fundamental understanding of the disease. Are we too far behind because we've been so focused on just treating COVID-19 that we haven't given it the due attention that it needs? Bruce Uhal, you are muted. Sorry. Yeah.
Well, one of the problems is proving mechanism often requires animal modeling. And there's still a lot of arguing going on about what constitutes a reasonable animal model for COVID-19. But what you and I, Philip, have theorized that IgMs coming up at day 8 may be causal if there's deposition, and others have published already deposition of antibody complexes, autoimmune antibody complexes in various organs, in the kidneys, and so that. But that, proving that these sorts of things are causal really, at least classically, required animal modeling. And then, from, for example, pathological specimens, you can get data that are consistent with such an interpretation. For example, we've looked for in specimens, pathological specimens of lung, for a human lung, for IgM deposition in the lungs, for example, which if found is consistent with the interpretation that this was causal for organ damage. But really you need an animal model to prove that. And a lot of people classically were asked, as I was years ago by the NIH, to use mice because you can use all the knockouts and so on. But mice are a poor model for COVID because it's differences in the sequence of ACE2, and then people generated humanized ACE2 knock-in mice with a human ACE2 sequence, but that has problems. So that's sort of where we are. How do you prove causation to any one of these proposed key events that we've been talking about that we really don't know yet? What's the key event that
that long COVID is a multiplex disease, that it's not only perhaps a hypersensitivity reaction to S1 spike, which I think is possibly a mechanism, but because of you have to take the whole patient into account. We know that there are predispositions to severe COVID, right? Obesity, high hypertension, uncontrolled type 2 diabetes, metabolic syndrome, frailties in general. These, Philip has pointed out, are attended by soluble ACE2 in the blood, that's leaving its position in the endothelium and migrating into the plasma. And there could be forming complexes with virus right away. And then you get IgG coming in. Now you really got a fur ball, that leads to macrophage activation syndrome. And now when you've got macrophage activation syndrome and massive inflammatory responses that could lead to the syndrome of post-viral syndrome, You also have to then say, well, if the immune system now is dysfunctional in that state, what happens to the latent viruses that the patient harbors? We're all probably carrying EBV or other latent viruses. What happened? Are we evoking again a chronic COVID presence rather than just spike protein? Therefore, my caution is, and I've been sort of trying to get to this theme of attacking the inflammation, yes, but not doing it in a way that would really compromise the immune system. And much of our anti-inflammatory armamentarium that we conventionally deploy in severe inflammation is immunosuppressive. I mean, I can IL-6 inhibitors, gamma interferon inhibitors, TNF, all of those biologicals are attendant with real warnings about inflammation. Immune suppression. So the theme that I think one has to attack long COVID with eventually is going to be, as the French say, frapper lentement. You have to hit, but gently. You have to try and approach this long haul disease with annoying but not life-threatening symptoms. Okay, with interventions that are going to be well tolerated, that are going to be oral largely, and that are going to be relatively inexpensive. And that should be, yeah.
Here's a question. I don't know if anybody wants to take this one. 20 million cases of ME before COVID. Are we likely to have 20 million more related to COVID and the impact that that's going to have on the economy and so on? I don't know if Tim wants to say anything about this reality.
I'm seriously worried. I think that that is a reality. When we look at studies of CFS-ME, the recovery from CFS-ME is something like 35. These are figures that are just in my head. 35% have full recovery, 40% have half recovery, 50% functional recovery, something like 25%, I don't know if the numbers, between 20 and 25% have ongoing significant morbidity related to their CFS-ME, of which can be presenting and persisting. And so I think the answer is yes. I do think we're going to have this persisting. But I think it's fascinating that, just going off on a bit of a tangent here, that we've not talked about the whole person. Well, Bruce, you were hinting at it just there. John, you were hinting at it, which is really refreshing, because in a way what we've been focusing on here is therapeutics, be it conventional mainstream therapeutics, but also nutrichemicals. Okay, so that's what we're focusing on. But hold on, shouldn't we be, and like you said, John, okay, which is, and you said, Philip, where's the mechanism? Which is the prime fault here? Where is the core? Maybe it's a bit of this, bit of that. In some patients, some things, patients other. We're never going to have a sniper to shoot that one thing. We need a bit of a blunderbuss, using that analogy. Apologies. And being less selective, pinpointing stuff, because maybe there isn't one magic bullet, etc., for that sniper. And maybe we should be actually thinking about looking at taking that whole person approach and looking at the body. How do we make that body work better in the long hauler? What are we doing? We need to be focusing on the gut microbiome, because of the gut-brain axis stimulatory. We've got to be thinking of that mixed, balanced diet, not just going after as you said, the xanthols, the carrots, etc. John, we've got to be thinking about the psycho side of it. Okay, we know that the autonomic nervous system, the way that affects the limbic system, the amygdala, is main wired. We've got to somehow incorporate that with those other therapeutic, if you like, holistic and whole body optimization of looking after the whole body, because the body is not Descartesian. We all know this with the mind-body link, etc. So hold on, the emphasis is on the whole person, and we've not talked about that this whole presentation. It's fascinating, I feel. So that's the way forward.
Yes, indeed. I mean, look, for example, we know that the population, as the Western population at least, is deficient in certain ways, and it's because of its dietary habits and its way of life. I mean, we're indoors too much. When we're indoors too much, we don't get enough vitamin D, and vitamin D is very important in immune regulation and inflammation regulation. We don't get enough NO2. NO generation, nitric oxide, which again comes from sunlight and from exercise. That's another predisposition situation we put ourselves into. Our zinc levels are low, and zinc is an essential ingredient in proper immune response. So when you start to look at the predisposing elements towards getting COVID in the first place and reacting to it, that all focuses down on what you're saying, Tim, is that the lifestyle, the dietary habits, the exercise habits, etc., are very, very important in terms of predisposition to this disease and long COVID in the end. But the thing we cannot get away from is what Philip is interested in, is the genes, okay? So there are people that, despite everything, don't get autoimmune disease or don't get post-viral syndromes, and others, despite maximizing their lifestyle and their nutritional habits, still get autoimmune disease and post-viral syndrome. So it's a mix of lifestyle and genetics. You can't do anything about your genetics, but for goodness sake, take account of your lifestyle, maximize and optimize your dietary habits, get some exercise, get some proper sleep, get some sunlight. That's a very important ingredient. I know it's very rare for Tim in England to see it, but I'm an African, and so I see it. I see it a lot, and I enjoy the idea of it. Not excessive sunlight. You get other problems with that, but 15 minutes a day of sunlight is a very important thing for everybody, I think, for all kinds of reasons.
And I'm sorry, go ahead, Tim.
I agree. And so patients say to me, okay, doc, what do you take? And I say, I take two things. One is vitamin D spray under my tongue. Love it every morning as I'm having a shave. Second thing is I take fish oils because, yeah, I love fish, but I probably don't get enough DHA and EPA. So right. That's what I take, patient, etc. So that's good. But I mean, going on from that, John, I'm going to put you on the spot here. I'm going to say, John, if you had long COVID, what would you be taking?
Okay, that does put me on the spot. No, I am. Look, I'm. There are several things. I had, in fact, a syndrome back in 2015 that laid me low for 10 weeks in hospital with a similar cytokine storm phenomenon. I developed all kinds of autoantibodies. So what am I taking now? I take low-dose naltrexone. I take vitamin C. I take vitamin D. I take aspirin as a baby aspirin for antithrombotic things. I take zinc. I
didn't mean to get. Actually, I feel really guilty asking you this. I
thought that was a good question, and I intend to ask everybody the same question.
It'll be a long night.
I think, though, that if somebody were to get a good multivitamin, multimineral supplement, not that I'm saying that it should be for everybody, but if somebody is in a risk group for COVID, I think that they ought to pay attention, first of all, by trying to get themselves off of that risk group by by getting rid of their obesity and taking care of their diabetes type 2 and taking care of all of that. So by other medical and other nutraceutical means. But if they're in a risk group, then certainly make sure that their vitamin D levels are proper, that their zinc levels are proper, and that, yes, they get sufficient omega-3s, which are anti-inflammatory and anti-thrombotic, antiplatelet in their own right, and make sure that they get the 2 helpings of fatty fish a week, or if they can't, then maybe go to a capsule of the stuff.
All right, so Annette, what about you? If you had long COVID, what would you do?
Now, I will do what I think is necessary. So I think I would take vitamin B12 injections as a superoxide scavenger, ARBs to reduce the production of superoxide, and tetrahydrobiopterin to as a cofactor for enos activation.
Is there an over-the-counter alternative to DH4?
No, it's very expensive. It's only it's now only available for children with PKU, and because those children get very ill if they don't have it, it's a very expensive medicine. So it's only a supplement, and I don't think it should be so expensive, but it is.
What about you, Neil? Any thoughts? If you had long COVID, what would you be gunning for?
Well, as we mentioned, I would be looking at quercetin or something that stabilized mast cells. I'd be trying to, keep, like for an example, I have well-controlled asthma, and I'm really trying to be very careful about that at this time. So, I'm vaccinated, but still have to worry about a breakthrough infection, and then when I've had viral infections, that's what, in the past has triggered my asthma. So I'm trying to be very attuned to that. And here in Los Angeles, we're having an uptake in cases. I lost 4 coworkers and acquaintances to last winter surge in Los Angeles. So even though I'm vaccinated, I wear a N95 mask all the time when I'm practicing. And that can get really hard when you're at the 12th hour of a 14-hour shift. I want to rip that mask off my face, but I'm not ready to. So, I'm trying to continue to keep in place as many preventative measures as possible.
And Shankara, what about you? If you had long COVID?
Philip, I have to reiterate what Tim has said, both right and wrong. I think we all have different risk profiles entering this illness, and so we'll come out the other end a little differently too. So I think we must look at the patients we're dealing with as well. There'll be some common threads through this, so there should be some commonality in the way we treat it. So I think it's vitally important to look at the patient in front of us. Each one's got different risk factors. Each one's going to endure different injuries through the illness, and each one will come out different at the other end. But there's certain commonality in the mechanism of the injury, and so there will be some common ways of treating it, but we'll have to individualize it to every patient. So I don't like using the word normal. I'd say average. Normal makes some abnormal. So I think I'm average. There are those that are going to be on the opposite ends of that scale. And so I think we need to look at our patients and look at how they came into this, what their comorbidities are, and what their risk factors were at the start. And that will give us a good picture of what we're dealing with in long COVID with each specific patient.
Absolutely. And Bruce, any thoughts for you?
Well, I already take fish oil and vitamin D and a multivitamin every other day, but the other 2 daily. And I would probably go for the other over-the-counter that I take on a regular basis when my allergies kick in, either loratadine, or if the loratadine doesn't stop the runny nose, the diphenhydramine, Benadryl, but its sedative effects are sometimes prohibitive.
Right.
And yeah, I like the antihistamine idea.
So do I.
Aspirin. I also keep a bottle of aspirin in my backpack.
But a lot of the things we've mentioned do have antihistaminic activity and anti-mast cell degranulation activity. So there are a lot of the things that we mentioned, like quercetin, like vitamin C, et cetera, have that in there. One molecule that was a double-blind study, a small one, but a very promising one for post-COVID, it was recently published, pre-published in the, in the internet, in BioRx or whatever it's called, but it's the methylated form of nicotinamide or niacinamide, and this is a metabolite of niacinamide, which in turn is a metabolite of niacin. But niacinamide is a very interesting anti-inflammatory nutraceutical, and I'm going to start looking more deeply into it as a potential modality for downregulating inflammation. It's got interesting properties, and it's not just
You're going to say something, Tim?
Yeah. Okay. Yeah, we've been talking a lot about therapeutics, how to treat it, how to treat long COVID. Okay. Right. What about prevention? Okay. We haven't talked about prevention. Okay, so what are we facing in the UK right now? We're looking at a third spike. It's just mounting up as we've unmasked. Freedom Day was last week. We're looking at a further escalation. Australia, look at it. What's happened to Australia? They've gone into their third lockdown also. So this is what we're looking at. Okay, let's think about prevention. How are we going to prevent these people getting it? Okay, it's all very well trying to deal with it, which is really important once we've got it. How are we going to prevent it? Okay, so it strikes me that what are we patients telling us? The patients are telling us, okay, I only had it mild. I went back to work a week later, and then I started running again 2 weeks later, and then it came in and it floored me, and I've now got long COVID. So what is this story? It's anecdotal, yes, but this is what is quite consistent. Patients, surprising, and they're usually the young fit ones, okay, 30 to 40s, who are regular swimmers, runners, joggers, and they go back to work too quickly. They go back to exercise too quickly, and then bang, they are floored. Surely we should be thinking about stopping these people getting it. Public health advice, there should be some sort of study looking at and thinking about this, because we should be telling them, there were guidelines back in sort of summer last year, again in the British Medical Journey. I took it out of my presentation, but they were saying, right, you should leave it a week before you should go back, a week after the last symptoms gone, then go back to exercise, etc. Hold on, shouldn't we be saying that we should be leaving it 4 weeks? Shouldn't there be some emphasis on prevention?
Does anybody understand why that mechanism would occur so consistently with exertion? Why would this then trigger a long immune mediated response? Does that make any sense? Has anybody ever seen anything like that clinically?
Well, it's a strong feature of chronic fatigue syndrome, myoencephalitis. I mean, exercise intolerance is a marked aspect of that disorder, and I think they're the same common pathway. So it was pointed out that exercise does disturb again the superoxide balance, and then causes profound release of inflammatory moieties. So it's an important consideration. It's probably the excessive sleepiness and lassitude and exercise intolerance are maybe warnings. I mean, kind of a mechanism to say, don't do this. You're taxing yourself. It's the old idea of athletes pushing themselves, past tolerance in terms to try and get their being more fit that way doesn't apply in this situation. It's contraindicated.
If you had a broken leg, the orthopedic surgeon would say you're not to be weight bearing for earlier than 3 months.
Correct.
So, it's because you can't see it, you can't see a COVID infection. It's all microscopic. Okay. The patients don't understand that concept. Let time heal.
Listen,
what exercise does is activate enos and the production of BH4 in the endothelial cells. That's what exercise has to do. And if you're not well yet, if you have an inflammatory disease, or if your endothelium is not healthy, then you don't produce nitric oxide, you don't produce tetrahydrobacterium, you produce superoxide. So if you start training those people, then they will only produce superoxide more and more.
But what I don't understand is why would it persist? So meaning I could understand if they then exercised, got knocked down with almost an inflammatory process, one would expect that even after a month or 6 weeks, it should have gradually resolved with rest. This doesn't seem as though it happens. Why is it that once triggered, it doesn't settle?
Maybe you've created...
I think it's the disorchestration of angiotensin 2 and angiotensin 1/7. It's an ACE2 deficiency. That's what I think. So ongoing enos uncoupling. Enos keeps producing superoxide instead of NO.
But what happens though, Phil? You've been talking about autoimmune phenomena, right? I mean, once
sounds different. This is not sound. This is why I'm asking the question. Is that I'm listening carefully to it. I know that there is probably an autoimmune trigger at the beginning, and I can understand a pattern where people have a continuous trigger that continues to cause symptoms. But what they're describing here, and I don't usually see these long COVID patients, but this automatically strikes me as an outlier symptom, where the pattern is triggered by them doing exertion, and then it doesn't go away. That is really, really interesting. That to me must point right at the pathophysiology of what's going on.
I don't think it's caused by exercise. It's exacerbated by exercise.
I understand, but whichever way you take it, even though it's triggered by the exercise, why does it not settle once they start to rest? Because they suddenly feel
it does. Apparently, when they start to rest, they get a bit better after a short while. It's just that pushing themselves towards exercise is a bad idea. You don't want to. Yeah, I have a feeling that we're dealing with, as I said in the past, a multiplex causality here, and it's the S1 protein, which can form complexes with soluble ACE2 and also with IgGs as those come along. And then with IgEs as those come along, and that then gives rise to mass degranulation and all these other phenomena. But it also could be reevocation of other viruses. It's a very complicated picture. Ultimately, we're going to be treating, I think, by as gently downregulating inflammation as we can, whether this be by extant drugs like hydroxychloroquine, ivermectin, low-dose naltrexone, etc. Antioxidants that are nutraceuticals like astaxanthin, vitamin C, quercetin, etc., etc. And then we're going to come along with more specific pharmaceutical interventions that have done the double-blind studies, whether it's Neil's drug that's done that, or it's my drug that's done that, the SP16, the peptide I'm talking about, or whether it's another pharmaceutical product that comes along, like one of the CCR5s that Bruce has been looking at, because I've done some research on this, is a monoclonal antibody called leronlimab, which is a CCR5 antagonist by being an antibody to that receptor. And that's under investigation for acute viral disease, for cancers, etc., as well as for COVID and now for long COVID. But it's an expensive intervention, as all antibodies are. So, in the end, I think we're, as doctors, we're faced with realities. Patients need help now. And the best way, I think, is to study the literature hard, use things that are non-toxic as first choices, because if you're wrong, you're not going to be causing harm in the doing of it. And then various of these formula will arise. There are a lot of ways to fly to London, but getting to London is the objective, right? And so whether you take American Airlines or KLM, you'll get there. But the formulas are going to be very different in different people's hands, and many of them will work. And it's going to be thinking hard and trying things out and reporting on the results in the good old-fashioned way that we've always done it.
You were saying something, Tim?
Okay, so John, flying to London. I like that one. But okay, you reeled off a lot there. It's maybe this, maybe that, maybe we just don't know. Maybe this, maybe that. And playing devil's advocate here. You remember that great quote from Voltaire, by Voltaire: "Medicine entertains the patient while nature cures the disease."
Right.
Get that? Medicine entertains the patient while nature cures the disease.
Yeah, but medicine is one step ahead of nature. That's its whole purpose, right?
But you did reel off lots of maybes.
That's true.
Yeah. So just before we're probably going to close up soon, I want to share something with you all and ask your thoughts on it. So my experience with seeing patients on a regular basis with strange symptoms, I'd see them in clinic with odd neurology and so on. And I found easily more than 95% of patients, if I spent a few minutes with them, I could identify what their problem was. Because once they start telling me that they got palpitations, they got numbness, they've got, they usually have gut problems. And when I quiz them, their gut problems have predated everything by about 10 years. So very quickly, I started to tell a lot of patients, listen, it's quite likely you've got a food intolerance. And it could be any other big things, but it could be as well some preservatives. And what I found is consistently, I could find the issue with most patients. And it is quite remarkable. And you just say, cut it out of your diet. Because in the same way with long COVID, I believe that we will find that there is persistent immune activation triggered by something that we just need to identify. And it's usually the diet that's causing the problem. Any thoughts on that?
Philip, I found very much the same. And I think John's look that we're having a myriad of different mechanisms at play. I've noticed with patients as well that their symptoms are not consistent. I see patients who present with breathlessness for a day or two. It seems to have resolved. It comes back. Some patients present with body aches and pains, and then it resolves and it's back again. So there's this up and down in symptoms constantly with long COVID patients. It's not just a steady, consistent symptomatology that you're dealing with. So it's like a firework going off repeatedly. They think they're resolving, and then it worsens again, and then they feel like a little better, and then symptoms change a little. So I think we're dealing with a mixed mash of mechanisms that might be influenced by external factors. And we need to start to investigate how diet and lifestyle and all those kind of things influence the illness itself.
Mm-hmm.
But they all manifest at day 8. This is an interesting, what's happening in day 8.
That's where we need to focus. We might be too far away from the crime scene.
Well,
Well,
That's the interesting
at day 8, you're going to get your IgG, IgE production. So, I mean, that's where I'm sort of, now I know I've got this narrow view of the world through FC receptors and, and how I interpret that. But, the timing is very suggestive that as the adaptive immune system cuts in, that it's then exacerbating, what leads to long COVID.
Mm-hmm. Yeah,
a
wonderful.
very, very good hypothesis.
So listen, guys, I think this was absolutely fascinating. I like the fact that we don't usually have any pressure in this second part, so we can just usually just relax and chat about whatever comes into our heads. But yes, thank you very much to everyone. I know this was very beneficial. The way how it usually gets consumed on LinkedIn is that people watch it in their own, because many people don't have time immediately on a Saturday to watch it, but they will all have the reminder that they'll go back to and then take a look at it in a day or two. So wonderful for sharing this with us. I'm glad for the people who had stayed with us all the way to the end. Somebody just asked a question, but we'll not take this on now. We're just about to close out. Kevin, thank you very, very much. And thank you very much, Vejon, as well, for sticking around with us for the whole duration. So wonderful, guys, and I'm sure we will be in contact in the future. Have a great evening to everyone.
Thank you.
Take care.
Bye-bye.
Thank you.
Take care.
Thank you,
everyone.
Thank you. Bye.